Dear Chairman, ladies and gentlemen, first of all, I'd like to thank the organizers for the opportunity to give this presentation here and also for the challenging title. These are my disclosures. When we have to choose for neoadjuvant or adjuvant treatment, we have to think about the situations. The classical situation is borderline a locally advanced pancreatic cancer where we consider neoadjuvant treatment, but we also should think about resectable disease. When we're aiming at preoperative treatment in a borderline or locally advanced situation, of course we want to increase resectability. So we want to convert a borderline disease into resectable disease. We want to achieve tumor shrinkage and maybe even achieve the R0 resection rates to go up. And maybe also we could target occult disease, so micrometastases, as you just heard from Marco Bruno, that are there already at early stage. Talking about borderline and locally advanced disease is a difficult issue, mainly because this is not very well defined. And as you see here, this is a very nice review recently published in the England Journal by Ryan and colleagues, and you already see that there's a continuum between resectable and unresectable, and there is a dark zone in between which is somehow borderline. And that makes it very hard to decide what is actually a borderline disease and what is deemed resectable first of all. We have no universally accepted criteria for that, and they are not clearly defined in many studies. And the definitions of borderline resectable pancreatic cancer do vary, and there are various criteria available from different societies, and I will point that out to you in a minute. The Meta-analyses consider unresectable and borderline resectable as one group, so they don't differentiate, which makes it also hard because I think they should be considered differently. And there is one suggestion regarding the veins, which is the matter of debate in this setting, that the resected segment should be downstream from the entry of the jejunal veins, and involved segments of portal or superior mesenteric veins should be less than 2 centimeters in length. This is sort of a consensus approach. These are the criteria as they use today. This is the MD Anderson, this is the NCCN guidelines, and this is the American Hepatobiliary Pancreatic Association. And as you see, there is quite a good consensus on the superior mesenteric artery and the common hepatic artery, but it differs already in the celiac trunk, where the MDACC says abutment is still regarded as borderline, whereas the AHPBA says no abutment or encasement is allowed, and the same does the NCCN. With regards to the superior mesenteric vein, the situation is already different because there is various definitions: short segment occlusion, abutment with impingement in the NCCN, or abutment encasement or occlusion in the AHPBA criteria. So it's really different, and we haven't got a uniformly defined borderline resectable locally advanced disease, and I think we're in desperate need for that. And the question is, does neoadjuvant treatment improve survival in pancreatic cancer at all? And this is just for the segment of borderline and locally advanced disease. They are not differentiated. We have 3 meta-analyses available from Andruli, from Asifi, and from Gillen. They included a various number of studies. The Gillen analysis, even 4,300 patients. Different neoadjuvant regimens. This is still the pre-FOLFIRINOX and the pre-GEM plus nab-paclitaxel era. So we are actually based on the conventional treatments, and of course treatments, chemotherapy as well as radiochemotherapy has been included in these analyses. And you see the results and at the bottom in yellow, and you see this is a potential advantage for neoadjuvant chemotherapy only in a minority, whereas the Asifi and the Gillen analysis come to the conclusion that round about 1/3 of the patients do benefit from a neoadjuvant treatment. So in 1/3 of the patients we do achieve downsizing, maybe even downstaging, and R0 resectability. There are confounders in these trials that actually make the interpretation more difficult. The type of chemotherapy used, the kind of radiochemotherapy used. The trials included in the meta-analysis are both prospective and retrospective analyses, low numbers per trial, and lack of control arms in most trials. Most of these trials were single-arm trials. The resectability criteria did vary. I've just pointed this out to you, and as well as did the definition of borderline resectable cancer. And even the definition of an R0 resection is not uniform, and I don't want to go into that too much, but this is also a matter we should resolve as soon as possible. So what can neoadjuvant therapy do in initially unresectable patients? And as you can see here, we have actually quite uniform complete or partial responses. Around about 30% of the cases showed a complete or partial, mostly partial response. However, this is something we have to bear in mind. Our CR resection rates are only around about 60% in this case. And the median overall survival rates are not bad compared to the adjuvant situation after resection, with about 20 months in total. So, and this is much better when you compare this with a non-resected situation, bearing in mind that these are mostly non-randomized trials. And I would like you to focus now on the red bars, and you see that the median overall survival is more than doubled in the resected versus the non-resected patients after neoadjuvant treatment in both meta-analyses, but only 1/3 of the patients are converted to resectable, so there is a selection bias in that, and this needs to be also balanced against toxicity of the neoadjuvant treatment. So, leaving now the neoadjuvant treatment in locally advanced disease and coming to the resectable disease, and in resectable pancreatic cancer, the standard is still after resection adjuvant chemotherapy, and this is disregarding of the R status of the resection. And what we actually could see is, and these are data from the ASPECT-3 study as shown in the upper panels, that it doubles the 5-year overall survival rate from around about 9 to 20%. And it doesn't really matter whether you use 5-FU or gemcitabine. In both cases, you have a doubling of the 5-year overall survival rate. And below you see the data from Oettle from the long-term observation now in the gemcitabine patients, and you see there are some long-term survivors even with pancreatic cancer, albeit at a low percentage. We're talking about around about 5 to 10% of the patients. There might be some hope at the horizon. These are the fantastic data from the JASPAC trial using S1 in the adjuvant setting, and you see there are 2-year overall survival rates of 70%, which is tremendous, and the median overall survival in this study has not been reached yet, so with a hazard ratio of 0.56 in favor of S1 as compared to gemcitabine. And the gemcitabine data in this trial are actually fairly good and well comparable to those we have obtained in our trials. However, we don't know whether the S1 data are actually an option for Caucasian patients, because we've seen the data in the gastric cancer scenario, and there we could not transfer the data one-to-one into Caucasian patients. So we have also some information now when to start the adjuvant treatment. This is again data from the ASPECT retrospective analysis, and what we could see is that if chemotherapy is started up to 12 weeks post-op, there is no difference in efficacy. So we don't have to rush it. 12 weeks are still okay as long as we complete the 6 cycles of chemotherapy. This is the important fact. If you discontinue early, it's bad for the patient, but you don't have to start the treatment very early on. However, even with the best adjuvant treatment available so far, up to 60% of patients who undergo successful R0 resection plus systemic treatment relapse within 12 months. And just heard the example from Marco Bruno with a woman, an 8-millimeter tumor and metastases detected 1 year after surgery. And the question is, can we do better? And we have to really challenge the fact whether pancreatic cancer in any case is a localized disease. And these are data from the same group as the Yashida paper you just seen before, published in Cell 2012. This is a mathematical modeling. And what the group came up with, actually examining a lot of pathological cases, is the fact that pancreatic cancer might be actually primarily a metastatic disease. This is not really a contradiction to what you just heard before. This is small tumors, and this is the take-home message, actually confer a high chance of having already metastases, 2-centimeter tumors in up to 60%. And how often do we detect in practice a 2-centimeter pancreatic cancer? This is actually the exemption, not the rule, I suppose. Because there are cells with a very high metastatic potential, about 1 tumor cell per million, and they have the capacity to metastasize. And maybe neoadjuvant treatment, eradication of the disease prior to surgery, treating the systemic aspect of pancreatic cancer early on could improve the outcome later on. And there are even mouse models for this type of analysis, as shown here. This is also a very nice paper by Rim. And what they could show is that even pannins, so the precursors you just heard about from Marco, have already the potential to undergo epithelial mesenchymal transition, EMT, and migrate. They actually have not the potential to colonize. Only when you have a second hit, like a KRAS mutation or P53 mutation, these cells can localize later on, but there is a very early potential, even in the precursor lesions, to actually migrate as a prerequisite for metastasis. So what are the advantages and aims of a pre-op therapy in resectable pancreatic cancer? First of all, we may have an early intervention. We may avoid treatment delays. In some centers, there is actually a backlog with respect to surgery. Here you can actually diagnose, treat, go to surgery, and then have an adjuvant treatment as well. And you don't have to wait for surgery for quite some time. You can use this time. Secondly, you can target occult disease. I've just been pointing that out to you before. I think at least 70% of pancreatic cancer are primarily metastatic at diagnosis, even at small size, and this we may be able to do something about it. Maybe not in the past, but nowadays with more efficacious chemotherapeutic agents, we may actually have some efficient tools to tackle that. And of course, we have a unique window, and you may view this as an advantage or a disadvantage. We could identify patients with rapid progression who can be spared ineffective surgery. And this is also a disadvantage, of course, when you treat a patient deemed resectable and during chemotherapy you see metastases. Of course, the patient could argue, well, if you would have resected the tumor, maybe I wouldn't have undergone the metastases and I would have survived longer. We don't know that yet, but I believe strongly that patients actually developing metastases during a pre-operative neoadjuvant chemotherapy do have a very bad prognosis and should be spared ineffective surgery. And we have in this neoadjuvant setting the unique chance of analyzing the tumor and see what actually have we done. I don't think all patients will benefit from this kind of treatment, but I think we can identify very elegantly those who may do so using the novel molecular technology we have available. So, can neoadjuvant treatment improve outcomes for initially resectable patients? These are data, again, taken from the 3 meta-analyses. And what you see is the response rates are lower, but these are the older treatments. And progressive disease is encountered in around about 15 to 20% of cases. So when we actually talk to patients, we have to tell the patients that disease may be progressive and they may not be eligible for surgery any longer. And the zero resection, the surgical exploration has been tried in around about 90%, and the zero resections have been achieved in around about 90%. And you see survival rates in this group are much better, with around about 23 to 30 months. If you do not resect, and these are now the blue bars, then survival is much worse. So you have an improved median overall survival for the resected as compared to the non-resected group, bearing in mind that you have a selection bias for the resected patients. And the question is, can newer chemotherapy regimens now improve that? And these are data now from nab-paclitaxel plus gemcitabine in the neoadjuvant setting. You have to bear in mind these are small trials, 16 to 40 patients on average, and some actually used not only resectable but also borderline resectable patients. Usually 2 to 3 cycles pre-operative treatment of gemcitabine plus nab-paclitaxel, and you see the resection rate didn't go up tremendously. 75% only resected, so 25% were not resectable, either because of disease progression or because of other comorbidities that prevented surgery. The zero resection rate, but is very good. This is 95%, and in one study there was even the margin reported with 50% in the 1 millimeter margin and 0% in the 0 millimeter margin. Survival is, of course, not the idea in these small trials, and the toxicity reported is mostly neurotoxicity, hematotoxicity with neutropenia, but on average this was very well tolerated, and there was no major impact on the surgery. So these are just the data from one of the trials I've been pointing out to you, and you see very nice, you can see changes in the SUV as determined by PET, so PET may be also an early indicator of response in this setting. You can check also these patients by endoscopic ultrasound and use elastography, but this is not a very simple tool, so you have to have a very experienced examiner who does that. And this correlates also well with the CA19-9 levels. So if you have a response, you should see also a response in the 19-9. And interestingly, the long-term outcome does correlate very well with those who actually respond. You see that below, the progression-free survival and the overall survival was best in those patients with a good pathological response. And therefore, there are quite a lot of trials now going on examining this concept in the neoadjuvant setting. And because of this correlation that seemed to be sensible in the preliminary trials, a lot of them actually have chosen response as the major criteria. I don't think this is very good. I personally prefer much more disease-free survival. That's why our trial, this is the NeoNext trial pointed out in this table, we use disease-free survival. We examine preoperative and postoperative as compared to postoperative gemcitabine nab-paclitaxel. Of course, these are also all schemes including radiotherapy as another modality, and we don't know yet which one will be the best in the neoadjuvant setting in resectable disease. Of course, the same is true for FOLFIRINOX. There are also quite a few trials around examining this context in the neoadjuvant setting to really see can we push the boundaries and can we increase the overall survival for patients. Again, these trials are either used sequentially or in combination also with radiotherapy. And there are even comparisons between the two modalities, which I find quite interesting. I would like to point out one trial to you. This is the US trial. They pick the winner scheme, nab-paclitaxel compared to FOLFIRINOX, and then the patients undergo surgery and get adjuvant nab-paclitaxel plus gem or FOLFIRINOX again, and this will lead then to a larger trial with the best concept that survives from this trial. So what would be a future view on the neoadjuvant treatment of pancreatic cancer, resectable pancreatic cancer, and locally advanced and borderline? This I've taken from a very nice review by Puleo, which I would recommend you to read in the World Journal of Gastroenterology. And in the resectable stage, I think we will see more and more neoadjuvant treatment, maybe even radiochemotherapy, but most likely chemotherapy. In the borderline resectable, the same concept, and in the locally advanced, we will probably do induction chemotherapy or radiochemotherapy, albeit we don't know the best modality, and we will hear that now in the next talk. However, at present, I think for locally advanced and borderline resectable, the neoadjuvant treatment improves the resection rate. Yes. Resectability after neoadjuvant treatment has to be surgically evaluated. It doesn't. The imaging is not sufficient. Once we really want to know after a neoadjuvant treatment whether a patient or not is suitable for a zero resection, we have to explore him surgically. I strongly believe that. The best modality for this concept is not clear yet. Chemotherapy, radiochemotherapy, which kind of radiation, and larger trials with new drugs are missing. So I think we should discuss these patients on a case-to-case basis in our MDTs. In case of resectable pancreatic cancer, adjuvant treatment is still the standard. Maybe we're getting new and better drugs that are even more efficacious. The neoadjuvant concept, I think, is very promising. And it may select patients that are not eligible for surgery despite a resectable tumor, so we spare unnecessary surgery. And it may increase the cure rates, but of course we need phase 3 data. We have to consider toxicity in a preoperative setting. We don't need how long we should treat these patients and how long we should expose them to chemotherapy. And we don't also need whether the neoadjuvant part is sufficient or we also have to do perioperative treatment. So at present, I would strongly recommend to include these patients into trials. And with that, I thank you very much for your attention.